Hello, my name is Mark Schroeder. I'm an Associate Professor of Medicine at Washington University in St. Louis. We'll be talking about completed prospective clinical trials of JAK inhibitors for the treatment of acute graft-versus-host disease, focusing on Itacitinib and Ruxolitinib. The management of graft-versus-host disease has been dependent on two lines of therapy, initially prophylaxis, typically with calcineurin inhibitors and methotrexate, and the standard first-line treatment for graft-versus-host disease has been corticosteroids. There's no standard second-line therapy option available until recently. Graft-versus-host disease is associated with a high mortality, especially in patients who are not responding to corticosteroids. Itacitinib was the first JAK inhibitor tested prospectively to treat acute graft-versus-host disease. Itacitinib is a selective JAK1 inhibitor. Preclinical models using Itacitinib showed that this drug could impair production of cytokines, affect the differentiation, proliferation, and trafficking of T cells in GVHD models. This was a phase 1 study designed to test 2 doses of Itacitinib in patients with graft-versus-host disease. Adult patients, after undergoing 1 allogeneic stem cell transplant who developed acute graft-versus-host disease, grade 2 to 4, were eligible for enrollment. Patients with both treatment-naive and steroid-refractory graft-versus-host disease could be enrolled. 2 doses of Itacitinib were tested in combination with corticosteroids, 200 milligrams once daily and 300 milligrams once daily. The primary outcome of the study was to assess dose-limiting toxicity and safety of the 2 doses and to determine a recommended phase 2 dose. Treatment continued in patients who were responding until progression, toxicity, or study withdrawal. The characteristics of patients enrolled are shown in this table. At both dose levels, all forms of graft-versus-host disease organ involvement were represented. About half of people had grade 3-4 acute graft-versus-host disease, which is associated with higher mortality. Around 40% had not received any treatment for their graft-versus-host disease, and 60% were steroid refractory. A total of 30 patients were enrolled and 29 patients received treatment. The adverse events associated with this treatment are shown in this slide. Namely, infections were attributed to study treatment and cytopenias. There was a propensity at the higher dose of Itacitinib to have more thrombocytopenia than at the lower dose. Day 28 overall response rate was a key secondary endpoint for this study, and in both treatment-naive and steroid-refractory patients at both dose levels, there were responses. The overall response for treatment-naive patients was around 80%. Those with steroid-refractory disease had overall response rates around 60 to 65%. One patient in the 300 milligram group with a pre-existing thrombocytopenia had a dose-limiting grade 3 thrombocytopenia, which was attributed to graft-versus-host disease. These swimmer plots represent the individual best responses to treatment. Of note, responses occurred within 2 weeks of the start of therapy. Subjects that attained partial responses were observed to go into complete responses with continued exposure to drug. Corticosteroid dosing was able to be decreased in those that were on study drug and responding. By day 56, all patients on study either discontinued corticosteroid treatment or received a reduced dose. The investigators concluded that this oral selective JAK1 inhibitor was well tolerated by patients with steroid-naive and steroid-refractory acute GVHD. In data not shown, the pharmacokinetics of absorption showed no difference between dose levels, nor in patients with GI involvement of graft-versus-host disease that could affect absorption. The overall response rate for patients that were treatment-naive was 83%, and around 65% for patients with steroid-refractory acute GVHD. Based on the tolerability and higher incidence of thrombocytopenia, the 200 milligram dose was chosen over the 300 milligram dose for further phase 2 study. The first study to prospectively evaluate ruxolitinib's use for the treatment of graft-versus-host disease was REACH-1. Prior to this study, there were no FDA-approved therapies for steroid-refractory acute graft-versus-host disease. This is the first prospective trial of a JAK1/2 inhibitor for steroid-refractory acute GVHD. Based on preclinical models and retrospective clinical observations, ruxolitinib was thought to potentially have activity in steroid-refractory graft-versus-host disease. This study was an open-label, single-cohort, multicenter phase 2 study that enrolled patients over the age of 12 who had undergone one allogeneic stem cell transplant and had newly diagnosed grade 2 to 4 graft-versus-host disease that was steroid refractory. Steroid refractory criteria are shown on this slide. Progression of GVHD after 3 days of treatment, GVHD that had not improved after 7 days of treatment, or the inability to taper steroids. Ruxolitinib was dosed at 5 milligrams twice daily, along with Solumedrol at 2 milligrams per kilogram per day, or its equivalent. And after 3 days of treatment, ruxolitinib could be increased to 10 milligrams twice daily. Treatment was continued, and the primary outcome was overall response rate at day 28. Patient characteristics of REACH-1 are shown in this slide. As you can see, no patients less than the age of 18 were enrolled to this study. Peripheral blood stem cell source was the most common source of stem cells. Patients with both grade 3 to 4 and grade 2 acute graft-versus-host disease were enrolled, with around 60% of patients having grade 3-4 and 30% having grade 2. Primary indication for steroid refractory graft-versus-host disease was progressing after 7 days of steroids, but around 20% of patients were enrolled that had an inability to tolerate steroid taper. The overall response rate at day 28 is shown in this slide. Responses were observed irrespective of baseline acute GVHD grade, but responses were higher in grade 2 graft-versus-host disease compared to grade 3-4 graft-versus-host disease, with the overall day 28 response rate of around 55%. With regards to steroid refractory criteria, responses were seen across all groups, with an overall response rate around 50 to 60%. In addition, at day 28, 43 patients were on ruxolitinib and corticosteroids, and among these, over half had a greater than 50% reduction from baseline corticosteroid use. The duration of response is shown on this slide. The median time to response for all patients was 7 days. The median duration of response was up to 345 days. Overall survival was greatest as expected in patients who had a response to treatment at day 28, with 66% of day 28 responders making it to 1 year. Those that did not respond had a 1-year survival rate of 10%. Non-relapse mortality in those that responded at day 28 was 28% at 1 year. 4 patients had a relapse of the underlying malignancy. The safety of ruxolitinib in this patient population is shown and summarized. The most common adverse events. Of note, these adverse events are expected in patients with graft-versus-host disease. Treatment-related adverse events, such as cytopenias, did occur in the setting of ruxolitinib treatment. Because of the immunosuppressive effects of ruxolitinib and steroids, infections were a key safety endpoint in this study and are listed on this slide. Of note, CMV infection was observed in as high as 30% of patients treated with ruxolitinib, but there were no deaths reported related to CMV. This key infectious outcome deserves further follow-up in future studies. In conclusion, among patients with steroid-refractory acute GVHD, ruxolitinib combined with corticosteroids was associated with an overall response rate at day 28 of around 55%. This response rate was associated with the grade of GVHD, with those having grade 2 graft-versus-host disease having higher overall response rates at day 28. Responses occurred at a median of 7 days and were sustained. Corticosteroid doses were able to be tapered in patients that had a response to ruxolitinib. Relapse rates appeared low, and ruxolitinib was generally well tolerated with no unexpected toxicities. In conclusion, JAK1 selective and JAK1/2 inhibition has shown clinical activity in acute graft-versus-host disease. Itacitinib continues in clinical development at the recommended phase 2 dose of 200 milligrams daily in upfront treatment studies for both acute and chronic graft-versus-host disease, and is also being investigated in the prophylactic setting. Based on the results of REACH1, ruxolitinib was FDA approved for use in steroid-refractory acute graft-versus-host disease. This ends this presentation, and I would like to thank you for your attention.